Hi, everyone. Welcome to another episode of Back to Basics. If you're watching this, you're probably part of our private Facebook group, The Natural Gut Relief. My name is Dr. Vivian Asamoah. And every Thursday evening, we bring to you guys a special topic and a very, very special guest. And this evening is no exception. We've got Dr. Scott McKnight, who is an amazing colorectal surgeon serving our Katy, Cypress, and probably Memorial community as well. He's been in this area for many years serving our community, and I'll let him talk a little bit more about what he does. I thought it was very important for us to bring a surgeon who is usually the next person I refer you to, along with an oncologist, after the colonoscopy and once the diagnosis of either a very large polyp or what looks like cancer has been made. And y'all usually have a ton of questions for me at that point. And I typically don't have any of the answers because I'm not a colorectal surgeon. So wonderful to have you here tonight, Dr. McKnight. Tell us a little bit about you, why you decided to go into colorectal surgery. Everyone asks me why I decided to do GI, so I'm sure you get the same question.
I get it all the time, yeah. So thank you so much for the invitation. So yes, my name's Scott McKnight. I'm a colorectal surgeon, like she said, in Memorial City, Katy, and also service Cypress to some degree as well. So I'm part of the University of Texas, so part of the UT group. I'm one of, 14 people in my group, but there's several of us out here on the west side of town. And we do have a fellowship program as well. So we do train doctors of the future also, which is great. It provides me that educational component as well. So just, as a background, I always introduce when I'm speaking with a gastroenterologist, just sort of the difference between what you and I do. I think some patients don't understand that distinction because, you and I both do colonoscopies. Correct. You do a lot more colonoscopies than I do, but we both do colonoscopies. And that's kind of the overlap of our practice. But we're trained in a different way. We both went to medical school. You went internal medicine track. I went general surgery track. And then beyond that, you did some specialty work in gastroenterology. I did some specialty work in colon and rectal surgery. So there is overlap, but we treat sort of different conditions. I don't do surgery on the esophagus or the stomach or the small intestine necessarily, liver, pancreas, that sort of thing. My practice is really restricted entirely to the colon, rectum, and anus. As to why I went into it, it's not because it's glamorous or sexy or anything like that. But I knew early on I wanted to do surgery. Surgery was my passion. That's what I loved in medical school. And in terms of anatomy, I just really enjoyed abdominal anatomy. That's the part of the body that just made the most sense to me conceptually. I enjoyed it. I got into my general surgery training and found that colorectal surgery was very challenging. I enjoyed the pelvic surgery. You're in a confined space. It adds complexity to it. Doing anorectal surgery is challenging. Complex anal disease is a challenging procedure. And then really the big focus of my practice now, as you know, is robotic colon surgery. That's really where my passion is doing robotic surgery. I think it's a huge game changer for patients. I think they just do better. It's very fine dissection. The recovery is very nice. And so that I love about my job. I love the fact that colon cancer is treatable. That was another thing that drew me to colorectal surgery. There's some other abdominal surgeries that have a very, very poor prognosis. But if you catch colon cancer at an early stage, it can be extremely treatable. And so for me, I like that because my patients, generally speaking, do well. I mean, they have a good positive, outlook and outcome. So hopefully that answers your question.
100%. Absolutely. And there are quite a few things that, quite a few conditions where you need you need a medical and surgical approach, right? It's not either or, but it's that combination, right? So, diagnosing colon cancer or large polyps, we may find a very, very large polyp, very, very flat polyp, try and remove it. We're unable to. We're concerned that there's something more, and very often we'll refer to the colorectal surgeon to actually do a resection because the area is too large. Same with early stage cancer or even advanced cancer. And similarly with our patients with inflammatory bowel disease, whether it's Crohn's disease or ulcerative colitis, not responding to the treatment, have strictures or fistulizing disease. And very often we collaborate with the colorectal surgeon for those things. Hemorrhoidal disease. So there's some overlap, but in everything, each specialty has its expertise,
Right.
and sometimes it requires that combination of both. So we're very, very grateful to work with you. You take
Mm-hmm.
great care of our patients. We appreciate that.
Thank you. I mean,
So,
I think there is value in subspecialty work, to your point. I
mhm,
mean, I think that, especially in the luxury of being in a big city like we are, you have the value, and I don't do anything else, right? I don't do hernias and gallbladders, and
right.
this is all I do. And so it's just like anything in life, whether you're a surgeon, a doctor, whether you're a auto mechanic, whatever it is. If you do it every day, you do more of it, you just get better at it, right? So
Hmm.
it
Hmm.
becomes a volume game, and so I do think that improves patient outcomes. We know from a number of studies that higher volume centers, for the most part, carry better outcomes.
Yes, yes, yes. And well, in part that's related to the systems as well,
Hmm.
right? Higher
Hmm.
volume centers understand hopefully understand the systems and the processes needed to get those better outcomes
Hmm.
as well, right? So that's cool. So we're going to talk about colorectal cancer
Hmm.
today specifically, because as I said, a lot of the patients that I complete a colonoscopy on, and I have to unfortunately share that diagnosis. And very often when we see a large polyp or a large mass, we have a strong suspicion that it's malignant, right? We have a strong suspicion that either one, it needs to be resected, or it needs a second set of eyes, right? We need to really try and stage this and figure out where we're going. So I usually end up sending them to the colorectal surgeon, and as well as to the oncologist, right, to
Hmm.
begin that process. And so, Scott, when patients come to you, how are they after you've diagnosed, if you've done a
Hmm.
colonoscopy or you've had a referral, and the patient's coming in with, they said, I may possibly have cancer.
Hmm.
How do you sit them down? How do you have that initial conversation? Because I'm sure they're quite anxious by the time they get to you, right?
Sure. I just saw two this afternoon, and I just finished up clinic. So yes, that's fresh on my mind. I have to see it every day. Um, so first, when we bring them in the office, bring a patient in the office, my first thing is I sit them down in this office and I have a conversation with them. I gather all their data. So I make sure that I get your colonoscopy report, your pathology report. If there's any question, then I'll give the pathologist a call and
Mhm.
just say, hey, would you guys look at these slides again? Let's confirm the diagnosis. Depending on where it is and what type of cancer and so forth, or a big polyp, we may elect to do some staging imaging. So if CAT scans or MRI or what have you, if that's not been done already, then I also order those tests. We do some lab work as well, some tumor marker testing. So we get all that data together, and then I have a conversation with the patient and talk to them, get a sense of, okay, what symptoms are you having? Are you blocked? In other words, are you able to
Mhm.
poop? Are you eating? Are you having pain? Is there blood in your stool? And then we go through their complete medical history, family history. I want to gather as much information as I possibly can, so that I can give the patient as clear a picture as possible, early on in the interaction that I have with them. And if I
Mhm.
don't have all that information, then I'll say, look, we need to gather this, this, and this, and then we're going to meet back very quickly thereafter and put
Mhm.
together a game plan.
And usually, how do patients respond to that? Do you just get different reactions from
Yeah,
different patients?
totally variable. Yeah,
Yeah.
some people that come in, they already know their diagnosis. Maybe they've had a family member who's had colon cancer, so
Mm.
they kind of know what to expect a little bit. Maybe they've had robotic surgery before, so they kind of know what
Mm.
to expect with that. And then you have some patients that come in and not because of their fault, they just have had no interaction. They've had no
They
experience
don't
with this,
know.
and so they
Yeah.
don't know. And so early in a conversation how informed people are and how much you need to get into the nitty gritty, or whether you just need to kind of give them a high level picture at first.
Exactly.
You don't want to overwhelm people,
Yeah.
right? I mean, if
Yeah.
they're already there's a number of studies that shown when they hear the word cancer, the rest of the conversation
They're
just goes out
already
the door.
overwhelmed. Yeah. They
Right.
just don't hear
So
anything
you got to
else.
kind of get a sense of who those people are to know,
Hmm.
do I have this really intense conversation, or do I give them a big picture and say, you know what, Miss Jones, why don't you, when you come back, you bring your family member with you? And also provide them a lot of handouts.
Okay.
I draw patients pictures
Good.
on a diagram. I show them, okay, this is the part of the colon that we're addressing. I have a handout that goes through all my robotic procedures. These are the risks of surgery and so forth. So
Hmm.
patients, when they leave, they feel very well informed.
So that's great. Let's talk a little bit about the different types of surgery you would perform, right? So depending on the location of the
Yeah.
cancer, right? So what types of surgery options do you offer?
Sure. Yeah. So location and stage play a big part into it. Kind of looking at it in big categories, I would say in my world, you're either going to do a transanal surgery, so like a big polyp in the rectum that we actually go in through the anus. And I do these surgeries robotically as well. So we actually put air into the rectum, and we can look with a camera and go in
Hmm.
and surgically remove a portion of the wall. So that's one category, so transanal surgery. But then when you think about abdominal surgery, there's really three categories. There's
Hmm.
open, which is the traditional surgery that's been done for 100 years.
Hmm.
There's laparoscopic surgery, which is where you put air into the into the abdominal cavity, and the surgeon stands at the bedside and controls the instrumentation and the camera. And then there's robotic surgery, which is where you take the laparoscopic idea and instead you have the robot that's actually manipulating the instrumentation, which takes out a lot of human error and trimmer and things like that. It
Hmm.
allows perfect instrumentation and sewing and things of that nature. So pretty much open, laparoscopic, and robotic. I would tell you those are the three main platforms.
And when would you, I mean, it sounds like robotic surgery is your thing. That's something that you are very skilled at, have a lot of expertise at. But when would you opt for one versus the other?
Sure. So again, big picture is going to be surgeon experience and
Mm.
surgeon expertise. I mean, that's going to ultimately you want your surgeon to be comfortable with whatever mechanism he or she is choosing, right? So
Hmm.
if you're in a smaller town and the surgeon who's very good, but they only do open surgery, that may be what you have to do. And that's
Hmm.
okay. It's not that it's a bad surgery. It's just I think there's ways to do it better, get you out of the hospital faster, less pain after surgery. But as to when I would do open surgery, a lot of that's going to be the prior abdominal surgeries. If I have someone that's come in,
The
they've
hip.
had a number of abdominal surgeries, there's going to
Hmm.
be lots and lots of scar tissue. I know now this far into my practice which of those patients I can try to do robotically. I'll try to do most people robotically if possible, because I think again
Hmm.
there's huge advantages. But there may be some instances where I say, look, this is silly. I'm wasting your time. I'm wasting my time by doing it this way. But it's a conversation with the surgeon, looking at where's the
Hmm.
cancer, what's the prior surgical history. There's other factors that play into it.
So in terms of so when it comes to robotic surgery, are you
Mhm.
finding less post-op complications? It seems
Mhm.
like technically the technique is more precise, right?
Yes.
And then
Yeah.
post-op, are you finding less complications as well?
I have, and again, I think it's you got to. It's not just the tool, right? I mean, the surgeon has to be comfortable on that
Hmm.
platform, so that makes a huge difference. But yeah, I mean, I think that when I tell patients the advantages of robotics, I'm telling them things like less pain after surgery, faster return to normal activity, very fine dissection, lower hernia rates.
Hmm.
We're seeing less bleeding, therefore less, infection problems because you're not making large incisions.
Mm.
Um, yeah, patients just I found that they just look better in the office on that first visit. Like
Visit after.
yeah, they're not asking for refills on their pain medication.
Mm.
They're saying, yeah, I'm feeling pretty good. I'm getting kind of
Hmm.
closer to normal. I'm, getting around better than I ever expected. And many of my patients are just taking just Tylenol for pain at that first 10-day post-op visit.
Well,
So
that's excellent. Yeah.
yeah, I'm a very much a believer in the technology. Yeah.
Very good. Very good. So a lot of patients ask me, how much of my colon are they going to remove? And of course,
Mhm.
this depends on multiple things, right? But in general, when you're doing a resection, whether it's a right hemicolectomy, left, or
Mhm.
whatever, how much, what margins do you leave? How do you determine the margins for the
Sure.
resection?
Good question. So most of it's based on the blood supply.
Mm.
Usually that's just a very textbook answer. Like I can show them, and on the diagram, I do show them, okay, here's your right colon cancer. I'm going to remove from the end of your small intestine all the way around to where it turns, called the hepatic flexure, and all that's going to come out. And most people's first reaction is, oh my gosh, so much. And I explained to him, well, the reason is because that's where the blood supply that feeds the colon goes
Hmm.
to, and therefore that's where the lymph nodes are distributed. And so if you just
Exactly.
remove a small section, yeah, you may be sparing a lot of colon, but you're losing all those lymphatics that you should
Hmm.
be getting out to get a good oncologic surgery. And that's ultimately the most important thing. You've
Mm-hmm.
got to get a good margin on either side, and you've got to get all those lymph nodes out. Again, depending on what part of the colon or rectum you're in, the margin should be anywhere between 1 to 5 to 10 centimeters, but the number's not as important as really where's the blood supply.
The blood supply and that distribution into the lymph nodes in that area.
Right.
Now, I'm seeing quite a lot of rectal cancer in younger patients. I'm not sure if you're seeing the same thing. I'm seeing a lot of rectal CAs in our 40, 50-year-olds, right? And so when it comes to rectal surgery, it's a little bit different, right? Could you talk a little bit about rectal cancers and your approach, surgical approach?
So the treatment of rectal cancer actually is an evolution. If you go to our national meeting, that's one of the main topics is how do we treat rectal cancer?
Exciting.
And so we've shifted a lot of our thinking, and now there's much more emphasis on stage 2 and 3 cancers as to getting all of your chemotherapy and radiation up front, then followed by surgery. I think in the next 5 to 10 years, we may actually be shifting more toward not even operating on some of these people because we've seen such excellent response to radiation and chemotherapy. So right now, it's not considered standard of care, although we may be heading that direction to where if you have, let's just say, a stage 2 rectal cancer that responds beautifully to radiation, maybe we don't even operate on that patient. Maybe we just watch them. We do what's called a watch and wait protocol.
Got it.
So that's one extreme. In terms of surgical technique, the surgical options largely depend on how close is it to the anus, how low is the tumor, is this something that you can safely go in, remove the rectum, reconnect to the residual rectum with or without an ostomy bag or not, or is this something so low that you have to remove the anus as well? Again, that's going to depend on where's the tumor, how low is the tumor, how fixed is the tumor. Those are a number of factors that just have to be decided when you have that first visit. Some of the early cancers, the stage 1s, like I said, we'll do that transanal approach. So we don't even have to remove the rectum. We just shave it a portion of the wall away, and then we get the pathologic diagnosis from there.
So the location and the extent, the spread of the tumor makes a difference, right?
Correct.
When do you request endoscopic ultrasound? And this is something that some advanced gastroenterologists or endoscopists will perform to look at the layers, right? The submucosal layers. When do you ask for an endoscopic ultrasound?
So 10 years ago, I'd say on every rectal cancer patient, they get an endoscopic ultrasound. Well, maybe not, maybe even 5 years ago. Now, really, rectal cancer protocol MRI has effectively replaced endorectal ultrasound. Yeah. I mean, there are situations now to where we use it where either, let's say they have a pacemaker or some hardware that's going to prohibit them from having an MRI. That's someone we might do an endorectal ultrasound. Or if it's a patient that we're trying to decide between what we call T1 and T2, so very early invasion into the wall of the rectum, how many layers are involved. Sometimes MRI, that can be a limitation as to whether it's a T1 or T2 cancer, and sometimes, or even T2, T3, and we'll use ultrasound as a confirmatory test.
Okay. So it really does depend on what you're looking at. And
right.
Now, the big question always comes up, even for me, right after I finish the scope, am I going to need a bag? Am I going to need a bag? So when is an ostomy needed? What should you actually, how should we counsel our patients who are just even scared?
Very individualized question. There's not a black and white answer on that, unfortunately. There are a lot of nuances that play into that. Again, it goes back to surgeon technique. If you go to a low volume surgeon, you're much more likely to end up with a permanent colostomy. If you go to a high volume surgeon that's very comfortable in the pelvis and does lots of rectal surgery, your chances of needing a permanent bag go way down. We know that from studies. That's not just me saying that. So that goes back again to that experience play. Other factors that play into whether or not you need a permanent ostomy are going to be, again, how low is the tumor, right? Is it sitting right on the anal canal, right at the top of the anal canal? What is the patient's pelvic function like, their anal function like before surgery? In other words, I may have a 50-year-old man who has a very low-lying rectal cancer that I'm planning on putting him back together. But I may have an 80-year-old woman who her anal function is not very good at baseline. I'm not going to put her back together because her function afterward would be terrible. Yeah, can I anatomically reconnect her? Yes, but is that the right thing to do? Because if that patient is unable to control her stool and she's leaking stool all the time, that's no way to live. That's
That's a
worse than a
horrible quality of
colostomy.
life. Yeah, that is a horrible quality of
So,
life.
how age of the patient, anal function, other factors, prior radiation,
Mm-hmm.
how low is the tumor? Is it even, can we get a clear margin beyond the tumor? Have they had preoperative chemotherapy and radiation? All those factors play into whether it's no bag, temporary bag, or permanent colostomy.
Okay,
Yeah.
very helpful. So it's not for everyone. It's case dependent, right? It
Case
doesn't mean just
dependent.
because you have colon cancer somewhere that you're obviously going to get an
Not
ostomy.
at
This
all.
is a careful assessment and based on different, different reasons,
Right.
and concerns that the surgeon may have. So that
Right.
makes a lot of sense. So that should not limit anyone from
No.
seeing a colorectal
No.
surgeon.
And
right?
that's an early question, right? I mean,
Yeah,
people see me with
very
rectal cancer. That's one of the very first questions they
Yeah.
have. And so that's one of the first questions I answer
good.
is look, I know you got a lot more in your treatment to go. You got to get radiation chemotherapy. I said, but I think that ultimately we'll be able to reconnect you
Okay.
and we will not end up with a permanent colostomy. I can at least give them that initial impression. It may not always come to fruition, but I think I can give them that impression.
And after colorectal surgery, right, whatever approach is used, and if the surgery goes well, what does the follow up look like? What is the recovery time for most patients? We know that each patient is different and complications can arise, but on average.
So again, my answer to that, which is going to be individualized, is typically for most of these colorectal cancer patients, they're in the hospital maybe 2 days, 3 days. Some people go home day one, but most people, I'd say 2 to 3 is kind of a sweet spot. And then by the time they go home, they're eating solid food, passing gas, or having some kind of bowel function, taking a shower, up walking around, all that we accomplish before we go home.
Excellent.
Sending them home, we try our best to minimize narcotics. So we do provide tramadol or stronger if necessary, but most people find that Tylenol, ibuprofen, gabapentin, muscle relaxer, those can all be very effective. And I think people are pleasantly surprised at how little pain that they have doing this in a minimally invasive approach. And then I usually see them back at about 10 days out from discharge. By that point, we usually have pathology back about a week to 10 days out from surgery. And I like to be able to sit down with them face to face to go over their pathology results. I just find that calling them on the phone is ineffective because I think it's helpful for me to go through it in person.
To go through it, yeah. Yeah.
And then I can direct them, hey, do we need to get into an oncologist, to your point earlier?
Right.
But yeah, usually about 10 days. And then by that 10-day visit, I'd say most people will tell me, yeah, bowel function's getting closer to normal, pain's minimal. I'm just taking Tylenol now. Hey, when can I drive? Can I liberalize my diet? Can I go back to eating fruits and vegetables? Usually by that 10-day visit, I'm liberalizing them on that, just still having them not lift anything over 10 pounds for a total of 6 weeks. So another month of no lifting at that point. Then usually I see them back about a month out from that 10-day visit. If by that month visit, they look good and they're getting closer to normal and their incisions look healed, usually I cut them loose. And I say, you're doing great. Make sure that you stay up to date with your colonoscopies. I'll send them back to your office and say, look, you need to get your colonoscopy. Usually, I don't know what you tell patients. I usually tell them about a year from their first, from that index colonoscopy.
Exactly.
And then depending on how that looks, I usually tell people every 3 years for surveillance colonoscopies with a history of cancer.
Exactly.
Now, there may be a genetic syndrome, Lynch syndrome, or something where you need annual
changes the
colonoscopies,
protocol.
right?
Yeah. Excellent. So that's really good. I actually thought the recovery was a lot longer than that. So that is
It can
is
be.
wonderful.
It
can be depending on
And
but on average,
it's changed dramatically in the last 10, 20 years. I mean, when I trained 15, 20 years ago, we had people in the hospital for a week after these surgeries, 10 days with tubes in their nose, didn't get out of bed. They were on pain pumps for days. We've just changed the approach dramatically. And its patients have done better.
Yes, the outcomes have been much better. That is excellent. So, Scott, final words before we part. Thank you so much for coming on. But since this is Colorectal Cancer Awareness Month, what would you like to share with our tribe from a colorectal surgeon's perspective?
Certainly, as you preach, get your colonoscopy, right?
Colonoscopy.
Get your colonoscopy. If you're young, get your colonoscopy. To your point just a second ago, we're seeing it in younger patients and we're seeing it more aggressively. So definitely under the age, 45 and over, you definitely need to get scoped. Do not delay.
Hello, everyone. Dr. Vivian Asamoah. That was a fantastic conversation with Dr. Scott McKnight, colorectal surgeon here in Katy. We are going to put his information. So he's with UT Physicians. We're going to go ahead and make sure we put all his information in the comments so you know where to find Dr. McKnight. As a colorectal surgeon, he treats everything related to, as he said, anus, rectum, colon, that pelvic floor is truly the area he focuses on. He's an excellent colorectal surgeon. We had a few glitches there, so we got disconnected. I just came back on to say thank you guys for joining us this evening. We had a wonderful discussion. I hope very insightful about sort of, the actual surgical process that happens once a large polyp or an early or colorectal cancer has been established, the diagnosis has been confirmed. So I hope this helps. I hope it's helped shed some light and remove some of the anxiety and the fear that we all have when it comes to surgery. Again, thank you for joining us. My name is Dr. Vivian Asamoah. I'm an integrative gastroenterologist here in Katy, Texas, serving the West Houston community. I am board certified in gastroenterology, but my passion is truly in everything that's integrative, holistic, and functional medicine. So blending the best of both worlds. Thank you for joining us here on Natural Gut Relief. And if you know someone who should be watching this particular episode on colorectal cancer awareness, please invite them to the Natural Gut Relief group. Share this with friends. And we've got a wealth of information, a ton of information that we've shared with amazing guests over the years. So once again, have a wonderful evening and see you next week. Bye-bye.